where they did the original studies on VBAC safety. She practiced in Seattle for 16 years and then moved to northern Utah in 2001 and loved practicing out of Davis, Ogden Regional, and McCady for 13 years. She is now semi-retired to take care of her husband. She continues to support advocacy for women. She is a friend to Penny Simpkin and Chris Miller, and I would add you are a friend to mothers. Oh, went away. Oh, there it's back. Thank you. She is currently volunteering on the subcommittee for safety in out-of-hospital births. Dr. Zelenkov. Would you rather hold that? That's great. You have to hold it like straight in your mouth. Okay.
You guys will have to, you can hear it now. Okay.
There's this chair.
So, the reason I'm asking people to give me their emails is that I am in the process of writing a chapter and possibly a book on sort of the philosophy that I used in my obstetrics for the last 30 years. And I'd love to get your feedback, and the chapter that I've been working on is specifically on how to avoid C-sections. And so I'd love to write it and then send it to you, which will give you much more detail than what I'm going to give you tonight. And then you can send me back your comments and say what you think. And I would really appreciate it if you want. Basically, the keys to having a vaginal birth, and I'll take questions afterwards if anyone has any specific issues that aren't covered by what we're talking about, but the key to having a safe vaginal birth, in America, birth is a very strange experience. It's been way medicalized. In fact, there's a whole discussion with doctors from the East Coast saying that basically birthing in the hospital is like delivering in an intensive care unit. And so your labor is really managed in a very different way. And so if you choose to deliver in the hospital, which is the safest setting to deliver for the baby, then you need to go in there with a very active management and know exactly who you're dealing with and who your support systems are. And you need to make a really concerted effort to know what the experience is going to be like and what your expectations are. But avoiding a C-section starts even in the very beginning when you first get pregnant. The important thing is know when you get pregnant, because when you know that your post dates or when your baby is due, it just makes that much easier for you to manage. And if you're already on prenatal vitamins, taking care of yourself, and you know who your provider is going to be, then that gives you that self-confidence very early on in the pregnancy. The other things that you can do specifically are to exercise on a regular basis. There have been a meta-analysis, which is reviewing lots of papers, and they found that mothers who exercised 30 minutes a day, and that can even be power walking, had a 20% lower risk of having a C-section. And so that probably works by just getting your body really healthy, your baby's the right size, and you're more likely to go into labor on your own rather than have to be induced. Starting an exercise program that you like, whether it be swimming or power walking or Zumba or whatever is a comfortable exercise for you, will help to, if you do that regularly throughout the pregnancy, it does reduce your C-section rate. The other thing that I tell people is early in pregnancy is to start getting into a really healthy diet, which is a lot of midwives feel that having a diet that's higher in protein and lower in simple sugars helps your baby to be the right size for your pelvis. And one of the first things I ask a mom when she's coming in is what was her mother's experience with birth. Now the problem is nowadays that too many women have already gone through the whole C-section intensive care process. And so if your mother has had a C-section, you don't know whether you will have a C-section. But if you go back to your grandmother and say, well, what was her birth experience like? Then you will have a sense of what her labor was like, how big a baby she had, and sort of what kind of labor you can expect. Because nature designed us to sort of have the same kinds of labor, same size babies as our mothers. Our pelvises are built that way. And so in general, if your mother had 9, 10-pound babies in 2-hour labors, then you are a natural mother that you can deliver anywhere and not have any problems. But if you're the kind of person who, if your mother had a long labor and maybe a smaller type baby, then you want to be more serious about eating healthy, exercising, walking, and then when you choose to who you're going to deliver with, you want to probably go with a midwife first, because multiple studies have shown that women who deliver with midwives are less likely to have C-sections and less likely to have complications. The only caveat I would add to that is that if the midwife is part of a team, especially if you're delivering in the hospital, and so you have to know who her backup is. And so if her backup does a lot of C-sections, then she's probably going to have the same philosophy as her backup. And so you want to not only meet the midwife, but you also want to know who are the doctors that are going to be backing up. So when I first delivered my daughter, I was delivered with midwives in New York City, and I knew exactly who the doctor was going to be, who was going to get called in if a doctor was necessary, because I knew who I wanted. Those were the days when you could do that. Nowadays, you know, doctors are often in big groups, 5, 10 docs, and you never know actually who you're going to get. And so it's very important to pick small groups, doctors who have a good track record. In other words, if 4 out of 5 of your friends have been delivered by this doctor and they all had C-sections, then I wouldn't go into there thinking that you're going to have a vaginal birth, because there is a common philosophy in that group that says we're going to prioritize our time and the baby's health, and we're not going to really listen to the mother. And so you have to really investigate and research who you go to in the very beginning. So, but just like Jessica did, I mean, she changed who she was going to at the very end, because she knew, she could sense that these people were not going to support her, and they were getting more and more nervous. And I've taken care of so many women who the doctor said, oh, well, you're going to come in labor with a VBAC, and I'm going to give you a trial of labor, and the minute they walk in the door, they say, oh, sorry, you know, the cervix isn't fully dilated, or there's some reason why we can't do a VBAC, and so now you're just going to have another C-section. And that is such a hard place to be when you're in labor, because you don't really have choices. But I would tell you that even if you're in labor in the hospital, you can always ask for a second opinion. And talk to the nurses and say, I want to talk to somebody who's very pro-vaginal birth, or somebody who's good with forceps or something, to come in and tell me, do I really need the C-section that these people are telling me I need? So early in pregnancy, get to know your midwife, ideally, or doctor. Eat healthy, exercise. At 36 weeks, make sure you know the baby's head is down. I have seen so many patients who come in labor and the baby's breech. And if it's your first time pregnancy, then that baby was breech a month ago, and the doc or midwife just never bothered to check. And now you're in labor and you're having a breech, and nobody is going to support having a breech vaginal birth unless you walk in the door and the baby's falling out. So at 36 weeks, make sure you know for sure the baby is head down, because if the baby is breech, you have time to do acupuncture, you have time to do exercises, you have time for somebody to turn the baby. And so it's very important that you always know what position the baby is. And just like the one woman who came in and she was 8 centimeters, I mean, there was a good chance that she was breech all the way through labor. I have seen one baby in 30 years that turned in labor. And so it is possible, but I would say that 95% of the time, that baby was breech probably for the last week, and nobody picked it up. So make sure you always know what the position is, and I tell mothers that if the baby is head down, you can feel the baby's butt up here pushing to get out. And so if the baby's head is up here underneath your ribs, the baby can't push out, and so you don't get those big bulges telling you that the baby's in the right position. That's the other thing I forgot to tell you, is you want a doc or a midwife who talks to you and explains a lot of the stuff that's going on so it makes sense to you. You know, in other words, how can you tell if the baby's in the right position on your own? You know, that's something that should be just part of the natural process. And if your doctor walks in, or midwife walks in and spends 2 minutes with you and then walks back out, that's not somebody who's engaged in your delivery and in what's going on with your expectations and how to make things be what you want them to be. So seeing doctors or midwives who spend 15 minutes talking to you and listening to your questions and your concerns is so important, and that's probably the key way that you can tell that you're seeing somebody who cares about you. Because, you know, I don't know. My philosophy as an obstetrician was always that I don't know who this baby is. This baby may be absolutely perfect and the world's best gift to mankind. I don't know. But I do know that the mother who's coming to me is capable of having babies, is intelligent, maybe a mother to other children. And so my job as an obstetrician is to really take care of you. And that's the philosophy that midwives have always had, is taking care of the mother, to be with the mother. And so, unfortunately, our society tells us that we have to do everything for the baby. But it's really important to take care of yourself. And in doing that, you know there's instincts and intuitions. I always tell mothers, listen to yourself. If you are having a trial of labor and all of a sudden you're starting to have nightmares that something bad's going to happen, talk to your provider and tell them what's going on. And maybe there's something that should be done differently. But anyways, listen to yourself. And when you walk out of an appointment and you say, geez, I don't even know what went on in that appointment, I don't know what this person was talking to me about, then that's the, not the good situation to be in. And don't be afraid to change and to challenge the person that you're talking to. My daughter's been seeing a midwife down in San Francisco, and she walked in and just asked, they were doing an ultrasound to make sure the baby was head down at 36 weeks, and she asked the midwife to also check the fluid around the baby. And the midwife said, well, why do you want to know that? Well, she did. And there shouldn't be any question. If you want to know something, people should be willing to provide you with the answers, as best as we know that. So lastly, you've gotten there, the baby's head down, you've found a provider that you trust. Now you're in a situation where you're in labor, and so there's 4 things that are involved with labor, and they all start with P's. 3 of them are the traditional ways that obstetricians are taught, which are it's the power of your uterus, it's the passenger, the baby, and it's the powers, passenger, and what is it, Chris? No, that's the it's powers, passenger, and pelvis. You were right. And so, first of all, your pelvis you inherit from your mom. That's why you asked your mom early on about what her labor was like. And so, in general, if your mom had big babies, short labors, you're good. You're golden. You probably inherited the world's most beautiful pelvis. On the other hand, if your mom had 3-pound babies and had C-sections, well, that's an unknown. And I had a patient, probably about 8 years ago at Davis, whose mother had 3 sections. Her mother-in-law had 4 C-sections, and I felt this woman's pelvis, and I said, oh, you're fine, you've got a great pelvis. And she went into labor and she delivered an 8 3/4 pound baby with forceps, no tear. And so she did really, really well. And so the pelvis is something you inherit, but a good provider can tell you what your pelvis is like, and you know, but you have to trust that they're going to tell you the truth. Because I've seen doctors who told women that their pelvis was too small to have a baby. And so that's where you have to kind of trust your doc, but also look back at your own personal history and say, well, what happened with my mom? What can I expect? So the second one is the passenger. That's the baby. And the baby has to be the right size to fit through your pelvis, and the baby has to tolerate labor. And that's where if you're in, if you have an appropriately sized baby, you've eaten healthy, you've exercised, and the baby starts labor on your own, then that baby is doing well. But if your baby's a little bigger, then your labor is going to be a little longer. And so when you go into the hospital, you have to go in and hopefully you will not be induced, because induced labors are not the same as spontaneous labors. There's something magical about the uterus starting to contract on its own that tells you the baby's ready to come, and it tells you the uterus is ready. Now, occasionally women have to be induced. Maybe they have high blood pressure. Maybe maybe they have diabetes, and there's a higher risk that the baby could die if it goes too long in utero. Maybe the woman is post-dates, like 41 to 42 weeks, and has to be induced. That's always a situation to try to avoid, because spontaneous labor is always the one that's going to have the highest chance of vaginal birth. Now, if you are in spontaneous labor, that's the best way to go into the hospital if you're going to have a hospital birth. And if you're going to be induced, you probably have to go to the hospital, although I think sometimes people can do, certain midwives can do stripping of the membranes and things like that to encourage your spontaneous labor. But if you're in the hospital, you always want to try to go in spontaneous labor, because you're less likely to run into problems. So if you have the right size baby, it's in the right position, then once you're in labor in the hospital, you need to be very cautious about not letting anybody pressure you into having a certain time. They have a big study that came out called Safe Prevention of Primary C-Section. That's the first time C-section. And it has everything to do with how long your labor is. And what this study showed is that you can be in labor, in early labor, for up to 24 hours, and you should never get a C-section before you're 6 centimeters. If you get a C-section before 6 centimeters, you have not, your body has never gone into real labor, into active labor. So one of the things you need to be very careful about is, one, trying to labor as much at home as you can, having a doula who can help you at home to sort of navigate the early parts of labor, and then to go into the hospital when you're in more active labor, because the less time you're in the hospital, the safer your passage is probably going to be. Now, if you have problems, you just have to have a doctor or a midwife who's extremely patient. I've had patients who have had 36-hour labors. And so, you know, I just waited and waited and waited. And the rule of thumb is in labor is that if you're doing well and you're not exhausted, if you're exhausted, get an epidural. Just go to sleep, let your body relax. But if you can go without an epidural, it's always a little bit safer labor for you, because your blood pressure doesn't drop and your labor doesn't change, and it's easier to push the baby out. So if you need an epidural because you're having 36-hour labors, then don't be shy. Go ahead and get an epidural. Let your body relax, but just be aware that an epidural labor is not the same as a spontaneous labor. An induced labor is not the same as a spontaneous labor. So you have to choose to challenge your provider if you need to and say, why do I have to deliver now? I have an epidural, I'm happy, I want to sleep, and the baby's doing well, there's absolutely no rush. The only time you need to have a C-section is if the baby is not tolerating labor, or if you've decided that it's time for you to have that C-section because you feel like something's not right. But in general, the more patient you are with labor, you need to be able to challenge people and say, I'm only 4 centimeters, why am I getting a C-section? Because I've never even gone into active labor. Now, once you get into active labor past 6 centimeters, then your labor is more predictable. And in general, it's a good idea if you're in the hospital situation to avoid breaking the bag of water. You do that as a last choice. Because once you break the bag of water, there's a higher chance that the baby is going to have compromise of the cord and not tolerate labor. And so you need to not move to that as just a convenience. It should be done for a reason. Like you've been stuck at 6 centimeters for 4 or 5 hours and not made any progress. Okay, break the bag of water. Gotten stuck at 8 centimeters, get the epidural. But in the movie, remember, make sure the baby was in the right position when you got the epidural. And then in terms of the baby handling labor, a lot of times some doctors are very quick to doing C-sections and some are more patient and can read the strip better. But there are a couple of things you can do. One, if your baby's having dips because of the cord, you can ask for fluid to be given back to the baby through a little tube called an amnioinfusion, and that helps to move the cord off and reduce the number of distressing decelerations or decreases in the baby's heart rate. So they say, oh, your baby doesn't look like it's handling labor, ask for an amnioinfusion. That also is a good way to tell when you have the little tube inside as to whether your contractions, which are the power, the uterine power, if your contractions are not adequate, then you will not progress, and then people will say, well, you're not supposed to have this baby vaginally, but it may be that your uterus is just tired. So I had a patient who had 2 previous C-sections who wanted to deliver vaginally. She needed to go down to the University of Utah. She went there with her doula. She came in at 5 centimeters. They breathed and they worked through it, and they breathed and they worked through it, and I went by to see her because I wasn't delivering anymore. And I said, oh, you're going to do fine, you're 5 centimeters. Well, 4 hours later, I went back and she was still just 5 centimeters. And her contractions were literally every 6, 7, 10 minutes. And so I said to her, I said, just let them give you a little bit of Pitocin. And she says, well, isn't that going to make my uterus rupture? I have 2 scars. And I go, yeah, there's a small chance it might, but you probably will do fine. And so she allowed them to give her a little bit of Pitocin, and literally 2 hours later she was delivered. And she left the next day before I even had a chance to see her. So she was feeling so much better. So the key is not to be afraid of interventions, but you have to know when it seems appropriate. And if your contractions have some kind of spaced out and gone away, you need a little bit of extra help for the uterus to get this baby out. Lastly, when you go to push the baby out, you want to be really careful that the first thing is that, say, oh, everyone says you're complete now. That's great. And that's such a relief because you know you've passed that active part of labor. So the first thing you want to ask is when you're checked is the baby in the right position? Again, the baby can be facing down towards your spine, which is an occiput anterior position, and that's the good position for the baby to be in, to come underneath your pubic bone. Or it could be facing up towards the sky, which is associated with back pain and is associated with slower labors. So if they check you, first of all, you need to make sure they know what they're doing. But if they check you and they say, oh, baby's in a good position, OA, then it's okay to just let the baby rest and descend in a nice, gentle manner until you feel the urge to push. And then it's good to start pushing, because if you start pushing too early, you're going to get exhausted. And so you want to just let the baby naturally come down as far as it can, and once you start feeling that pressure down in that rectal area, then you start pushing. This is primarily for the first-time mom. So sometimes the baby comes down a couple of stations, then doesn't come down anymore. Then that's when you want to start pushing, but you've probably reduced your pushing time by at least 1 to 2 hours if you just wait. And it's less stressful for the baby if you're not pushing, so you're less likely the baby's going to get distressed. So the key is to make sure the baby's in the right position, rest and descend, and if you don't have an epidural, then you can squat and push the baby out and use more mechanical, more natural ways of getting the baby down. If you have an epidural, then you're going to have to probably push at least an extra hour. Now, the current standards, these guys have reviewed over 62,000 births, all of which women all came in spontaneous labor, and they all delivered vaginally, and you can push for up to 5 hours before the doctors can say you've pushed long enough. So if you've only pushed for an hour and the doctor says, oh, time to do a C-section, they are not giving you enough time to deliver your baby. So as long as you're comfortable, baby's happy, you can wait, you can wait, you can wait. And then ultimately see what happens. And then don't be shy about, make sure you have a doula who's experienced if you're in the hospital, because they oftentimes can help you and say, you know what, you really should be asking for more time. Now, if all of a sudden the baby's heart rate goes down, don't be afraid of letting the doctor, do a vacuum or forceps, because if you can get this baby out vaginally, you're in good shape. But I tell mothers I only do forceps or vacuums if the baby is in distress and I need to get the baby out right away, or if you're exhausted and you need help. But you shouldn't just have somebody just walk in and say, oh, you've been pushing for 2 hours, I want to put a vacuum on and get the baby out. That's not a good choice. There should be a very specific reason you should either be asking for it or the baby is in distress. And if you can get the baby out in 5 minutes with a forceps versus 15 minutes with a C-section, it's so much safer for the baby. But that's something to talk to your provider ahead of time. If you had a brother who was injured from forceps, maybe you don't want to have forceps. You need to talk to them and tell them specifically what your concerns and fears are. Very important. But in general, in good hands, forceps are the best way to get the baby out. And if you have somebody who doesn't have a skill level with forceps, then a vacuum is the second choice. But the vacuum isn't as sure of a deal in terms of vaginal delivery. And then finally, if you've had a VBAC, I know that there's people who say that if you had a VBAC, you pushed for 2 hours and you didn't get the baby out and had a C-section, and so you're not a very good candidate for a trial of labor. I have no idea how good the doctor was that did that initial delivery. And so if you did not have an attempt at vacuum or forceps, you are a good candidate for a trial of labor, because that doctor probably never gave you a complete chance to get the baby out vaginally. So, lastly, the fourth P is the place. And this is where, you want to have a place that you feel safe. And so for some people that is being in the hospital because you feel like you're going to be safer being able to handle emergencies. But for other people it's going to be at home, or it's going to be in a birthing center. And in general, all of them are safe alternatives. And so you just have to give yourself enough time to know all the different options and decide where you're going to feel safe. But I would recommend that if you're in the hospital that you really, really make sure you have a team of people who are there to support you. Because it's very hard to be able to advocate for yourself without enough knowledge. And I remember when I went into labor with my second baby, and I went in and I was 8 centimeters, and so I was going to be delivering pretty soon. They sent a resident in, and the resident checked me and said, oh, you're 7 centimeters, 8 centimeters. And she says, I want to do an ultrasound to make sure the head's down. And I looked at her, and I was in the middle of pretty intense labor. This was my second baby. And I just looked at her and I said, if you can't tell whether the head's down at 7 centimeters, go find somebody who can. And you know, my husband said afterwards, he says, I never realized how vulnerable women are in labor. You need to have somebody there who questions what's going on. And if there's a really good reason for doing something, don't be afraid to go down that path. But if you've been sitting in labor and you just feel like everyone sort of wants to just get you out of the way and down to postpartum, and in that you've just run out of time, then that's the wrong feeling to have, that you're being forced into doing something you don't want. And there was an interesting article that came out with a doctor who practices out on the East Coast. She was in labor, and she was in labor for 36 hours. And she said the whole time she was in labor, she was induced. She was induced because of the dates. And she said the whole time, everyone was in the back room talking about, when are we going to do her C-section? When are we going to do her C-section? And she wrote this entire editorial saying this was the most awful experience she had ever had. She ended up delivering vaginally and everything went well, but only because she was a doctor, because she was willing to challenge people, and because she had friends who came in and said, stop it. Don't make this lady feel bad because she's having a long labor. Because long labors are fine as long as you're happy and the baby's happy. Those were my only criteria. I didn't add up any hours, how many hours you pushed, how many hours you were in labor. My only criteria is your baby happy? Are you happy? If they are, we can wait. And so that's the criteria to keep, because everyone wants to have that perfect birth that's only going to be 6 hours long. But the reality of it is everyone has a variety of times. And so you want to just basically be able to find be able to trust your body to do the right thing as long as you're being monitored carefully. So, what questions do you have? Oh, and home births are great. In England, they're recommending home or birth center births as long as you've had your first birth at the hospital. I think here, if your mom had easy births, I think even your first birth is probably safe to have in a birthing center or at home, depending on how you feel about that. If you feel that that's the safest place to be, then just find a situation and a provider that you feel really confident with. So let me take any questions or anything that I didn't cover.
So if you were to ask for a second opinion, there in the hospital, would it be difficult to get an unbiased second opinion?
Probably, but it's worth putting people on notice that you are feeling that way. And I would say that if you have a C-section because they are saying the baby's not tolerating labor, I would ask for what's called arterial blood gases. This is a way that they measure how well the baby's tolerating labor by obtaining blood from the umbilical cord, and it will tell you right away, was this baby in good shape